Assalamu alaikum. Welcome to Jahra Day. It's my honor to be presented by my teacher, Dr. Abdulrehman. And thanks for the organizing committee to choose me to be speaker today. In the last 2 weeks, everybody was asking me what's the meaning of this address in a quest of a solution. Actually, when Dr. Asman asked me to give an address, it came to my mind. It's a case presentation, but at the end, we'll know why I chose this address. Usually, I like photos more than text. This gentleman, he's well known. He's a physician. We need him today in our case, but not as a physician. For other reason, maybe also at the end we'll know that. So today I will present a case. That case was actually managed by our team. It's not Abdulrahman or Thomas or anybody. It's managed by our team with the subspecialty. In summary, he's a 35-year-old Egyptian gentleman who was admitted to our floor in Ward 15 with a 3-week history of intermittent fever, skin rash, generalized fatigability, loss of appetite, and loss of weight, around 6 kg in 1 month. He denies any night sweat. He had a recurrent visit to the emergency department for the same complaint. He was told that it's only a simple viral infection, just took an antibiotic and you will be fine. This didn't happen. He denies any other symptoms. So systemic review was negative, no cough, no short breath, and there's no contact with any sick patient. This is as per the patient claim. No significant past history. He's a father of 3 kids. He's a sport teacher in a school, and also he's working as a coach in a gym, in swimming and bodybuilding. He denies any drug history, sexual history, or recent travel. We didn't write the whole history because of the time, but that was only the positive in the history. I need especially the juniors to concentrate on that. Physical examination. I will mention also the positive finding in the examination. He was febrile, temperature around 38.5, pulse 90 beats per minute, blood pressure 130/80. He had macular non-itchy rash in both upper limb and trunk. And he said it's associated with the fever. It came at the same time. The only finding was small mobile axillary lymph nodes. We thought it could, likely it's not non-significant, around less than 1 centimeter mobile. The rest of the examination was negative. There is no organomegaly. So, this is not the same picture, but this is similar. Maybe Dr. Shahab interested in that. That was similar to his presentation. That is the rash in trunk and upper arm. So, we started with the examination. Complete blood count. The WBC was 5.7, hemoglobin 9.4. He is a male. MCV 57, MCH 18, and the platelet 118. ESR was 39, CRP 20, ALT 440, AST 130, bilirubin normal, CK was 110. Peripheral smear, no abnormal cell. Malaria was negative. Ferritin was 200, iron 7, transferrin 14.8. We thought it could be anemia of chronic disease, could be iron deficiency anemia, maybe because he's working in a gym, could be because of the nutritional. So that was impression at that time. PAT-CAT, negative. Complement, normal. Coagulation, normal. T-spot, negative. This is the worst scenario for a physician. You want to catch something. Chest X-ray, normal. Urine, negative. Blood culture, negative. Sputum culture, negative. Ultrasound, mildly enlarged spleen. HIV was negative. We asked for, at that time, all investigation was free, so we were liberal in asking for viral screen, for autoimmune screen. It was sent. Patient was febrile for 3 days. That was during summer, so he said he wanted to go back Egypt. That is his vacation. We asked him to stay. He decided no. If he is sick, he will come back. So we are dealing with with what? We can label this patient as having fever of unknown origin. Let's remind ourselves about the definition of fever of unknown origin. Fever higher than 38.3 on several occasions, duration of fever at least 3 weeks, and search and diagnosis after 1 week of stay in the hospital. That is the classical fever of unknown origin, but with the definition now, it includes healthcare associated nosocomial infection, like C. difficile and rest of infection. Neutropenic fever is also included. HIV related, especially opportunistic infection and even malignancy related to HIV. Fever of unknown origin is the worst scenario as a physician to deal with, because around maybe 20% of cases will be undiagnosed. And in some reports, up to 30% is undiagnosed. But this is after doing all workup. So what happened to this patient? After 10 days, he came back with the same presentation, but he was more toxic, more lethargic, more fatigued, to the degree that he canceled his travel to Egypt. He don't want his family to see him in that bad shape. So we reviewed all lab again, which was sent in the first presentation. Everything was negative. Viral, as we said, HIV was negative from the beginning. CMV, EBV, herpes was negative. Autoimmune, ANA, double-stranded, ANCA, negative. Ultrasound from the beginning was negative. Echo, we did it at that time, there is no vegetation. B12 was requested also by hematology because picture initially looks like pancytopenia, but it was normal anyway. Ferritin started to increase, platelet normalized in the second admission. So what is next step in this patient? If you review the causes of fever of unknown origin, it's infectious, malignancy, autoimmune. So this is the majority. But as I said, there is 20% idiopathic. So let's see what we did for that patient. We did for him CT chest, abdomen, and pelvis. The finding, as per the report, that he had small axillary lymph nodes, small lytic lesion in thoracic, B5, B11, and organomegaly, hepatosplenomegaly, minimal pericardial effusion. So immediately we repeated the echo, but there was no pericardial effusion, there is no vegetation. So I think at that step, we thought that we are near to catch the diagnosis based on anemia, lytic lesion as per the report, and organomegaly. At least catching something is better than to be lost in the diagnosis. So, next. So the differential diagnosis was lymphoproliferative autoimmune infection. Patient was seen twice by the dermatology. Initial admission, the second admission. Second admission, the differential was almost the same. Could be infection like mycobacterial, could be vasculitis, could be drug, and they asked for skin biopsy. Patient agreed for skin biopsy. Skin biopsy. The report came as panicolitis. Does this add, change, or no? Nothing. It's, as we said, it's a panicolitis. So what is panicolitis? Panicolitis is an inflammation of fat, subcutaneous fat. It's uncommon. There are many subtypes. If you want to talk about it, you need more than half an hour. But let's concentrate on the causes of panicolitis. It is could be infection, mycobacterial, parasite, bacterial, trauma like iatrogenic, factitial, foreign body, enzymatic destruction, because at that time they asked for alpha-1 antitrypsin, amylase, lipase, because there is pancreatic panicolitis and alpha-1 antitrypsin can cause it. All were sent and were negative, and malignancy. So as a physician, when I saw lytic lesion, anemia, something called panicolitis related to leukemia or lymphoma, of course, I think I'm in that tract. In spite it's a nasty disease, but at least we want to catch it early, especially the patient is very sick, very toxic. And as we said, inflammatory. Erythema nodosum is part of the panicolitis. But there is different clinically. Clinically, the patient should present with a tender nodular lesion. But we presented the case the same what we saw initially. So We sent for myeloma screen. All were negative. The serum protein electrophoresis was negative. There is no bands. Skeletal survey negative. So is it part of the 20% which is idiopathic or something else? We don't know. So instead of the workup of fever of unknown origin, you need to do invasive procedure like bone marrow biopsy. So this patient agreed to go for bone marrow biopsy. We asked him to do that, to rule out malignancy, and to be sent for culture, especially for tuberculosis, salmonella, brucella. So the patient agreed to do that. The bone marrow biopsy, maybe Ahmed can catch it from the normal. Morphology, normal. There is no abnormal cells, no malignancy. The culture was sent negative for tuberculosis, negative for salmonella, negative for brucella. So should we stop here and say, khalas, this is of the 20% of idiopathic unexplained fever, or we should go to a step forward? Fever of unknown origin, every day you should examine the patient, every day you should ask him, and this is what we did for almost more than 1 month. But this is only the information we got it. So next, you will ask for what? Gallium scan? Gallium scan. We asked for a gallium scan, and we hide in the name of the patient, but sure it's done in Jahra. We can see there is increased uptake in both shoulder, right and left. The rest is normal. The lytic lesion, we reviewed the film with the radiologist. They said, no, it's not significant. But with the nuclear, we found there's an increased uptake in both shoulder. So we'll go back to slide number 1, to that person we said we want him to help us. He's a physician. He's said Dr. Arthur Conan Doyle. He's very famous, but not because as a physician. Physician never be famous, maybe if he did something else. He continued to be an ophthalmologist. He said, in my clinic, I didn't receive any patient. So he became a novelist, story writer. He was impressed by his consultant. His name is Joseph Bell. Joseph Bell was a surgeon. Both are Scottish. Not specialized. He was excellent in forensic medicine. The Scotland Yard was asking him to help in solving the puzzle. So Dr. Arthur Conan Doyle was impressed by his consultant, and he was featuring a character called Sherlock Holmes. Maybe most of people knows who is Sherlock Holmes. As a physician, you need to be like Sherlock Holmes. As a team, we stopped and we decided what to do for the next. As I said, that gentleman is very important in this presentation. So we did both, right and left arm MRI. The patient denies in history. He's a bodybuilder, very muscular person. This is the film. So the muscle was replaced by, or there's increased signal. It's a fluid, you can see, around the muscle. Some of the muscles start to be atrophied, and there is an oily-based fluid. And what is this one? This is soft tissue fillers. This patient, in spite we asked him more than 100 times about injection, about fillers, about any drugs. He is a coach in a gym. He wants to show the trainer that all his muscle is because of the exercise and the nutrition sold by the gym, but it's all are fake. He denies this information. He keeps asking us, please don't tell, because he is a very famous name. In his room, you will think this is a member of parliament or even a prime minister. He is well known, but all are fake. So we are dealing with the soft tissue fillers. He was seen by a surgeon. There is no abscess, no collection, and he was referred to the plastic surgeon. He is lucky that his fever subsided by itself after a few days, and he was discharged well. I don't want to write this is the type of filler. It's an injection, ampoule, just injected. I will talk in the next 2 minutes about soft tissue fillers. By the way, the patient, he accepts to go for bone marrow biopsy, which is a very invasive procedure, and he was hiding the information of fillers. There are two types of soft tissue fillers, temporary, biodegradable, or permanent. The temporary, hyaluronic acid, collagen, calcium, and the permanent is silicone, which is not used now, and methylate. There are many adverse reactions. The problem with the fillers that the manufacturer will tell you there is no adverse reaction. This is the problem. The other problem, it is nowadays, it is used in non-hospital. Even in a salon or a gym, they can inject. So the manufacturer will tell you there is no complication. It is done in non-hospital. At the same time, there is no registry, only scattered cases here and there. This is the problem with the filler. The adverse reaction, there are early and late. The dermatologist and the plastic surgeon, they are aware only about, not aware, they are dealing only with the early complication, which is very serious. Bruising, edema, vascular, necrosis, and blindness. Imagine that a female coming for cosmetic and she will be after a few days blind. It's very, very serious. Migration of the filler is also very serious. And there is late and delayed. I think this reaction, as a physician, we are dealing with it, causing nodule, granuloma, chronic inflammatory reaction, chronic infection like mycobacterial and bacterial. That patient, when we reviewed the article and we dig in more with the bodybuilder, they are using a substance called synthol, or they call it in English pompous, in Arabic bomboys. It's well known. You can get it from the internet, but it's supposed to be local. What they are doing, they are just injecting that substance. It's containing of 85% of oil, 7.5 lidocaine, 7.5 alcohol. There are many serious side effects with this substance, like unnatural muscle growth, muscle destruction, like in this patient, cerebral stroke. It could be because of the way of injecting, or migration, vascular occlusion, chronic infection like mycobacterial, pulmonary embolism. All are lethal complications, nerve damage, and lymphogranuloma, and cystic tumor. So all these are very serious side effects. And as I said, you can get it $10 from the internet. It's
sorry, doctor. 2 minutes.
Inshallah, I will. So the take-home message: all known fillers present in the market have been shown to be able to provoke early and late inflammatory adverse reaction. And the majority of late reaction are inflammatory and immunity mediated, because it's a foreign body, can cause allergy and can cause, in the long run, autoimmune process. So edema, granuloma, sarcoid-like, panicolitis, all can be a presentation of soft tissue fillers. As a physician, because this is a new modality, new regime of treatment, it's especially in our country, we should be aware of these side effects. Like what happened, this patient, he denied. He goes for invasive procedure and he still denied. There are many medical legal issues, so we should be aware of this side effect. Community awareness also is very important. Some hospitals now in Kuwait, they refuse to deal with this complication because the patient will, the doctor in the private will tell, no, this is not because of my fillers. It could be because of the correction by the government. So I think this is very serious. Like this photo. This guy from Brazil last year, he's well known. In 2-3 months, he built up all this muscle. He came to the TV, but he ended up what? Amputation of both arms because of the same substance which is called synthol. So, last message. Dr. Arthur Conan Doyle said, any truth is better than indefinite doubt. But Abdulrehman Al Shammari said, the good physician channeled the inner Sherlock Holmes. Thank you.
Thank you, Dr. Abdulrehman.